Assalamu alaikum wa rahmatullahi wa barakatuh. Bismillah ar-Rahman ar-Rahim. This is second lecture of inflammation. And the objectives of this lecture are: how does the inflammatory exudate formed in acute inflammation? To know the mechanism of increased vascular permeability and formation of inflammatory exudate. To understand the functions of inflammatory exudate. And what is transudate? How does it differ from inflammatory exudate? As we mentioned in the previous lecture, fluid exudation is caused by either increased vascular permeability, which is induced and caused by chemical mediators, or due to the direct damage to the wall of a blood vessel. We start with mechanisms of increased vascular permeability and formation of inflammatory exudate. The first mechanism of increased vascular permeability is immediate transient vascular response or vascular leakage. It is most common mechanism of increased vascular permeability. There is endothelial cell contraction, leading to the widening of intercellular gap between the endothelial cells, causing leakage of fluid or plasma and proteins from the lumen of blood vessels to the extravascular space or interstitial tissue. This endothelial cell contraction is caused by vasoactive chemical mediators such as histamine, serotonin, bradykinin, and others. Vascular leakage occurs rapidly after injury and lasts for 30 minutes. So, it is a reversible and transient process. The walls of blood vessels return to normal after 30 minutes of injury. Hence the term immediate transient vascular response. So, the vascular leakage occurs in the walls of venules only, but the walls of arterioles and capillaries are not affected and have no vascular leakage. This mechanism commonly occurs in a mild injury or mild inflammation. This figure shows the vascular changes in venules in acute inflammation, which are responsible for the immediate transient vascular leakage. Normal post-capillary venules are lined by intact endothelial cells, and there are no gaps between the endothelial cells. In acute inflammation, with the formation of chemical mediators of increased vascular permeability, such as histamine, serotonin, bradykinin, platelet activating factor, and leukotrienes. These chemical mediators cause contraction of endothelial cells, leading to the widening of intercellular gaps, which permit the plasma and plasma protein to leak from the lumen of blood vessels into the extravascular spaces or into the interstitial tissue. The second mechanism of increased vascular permeability is junctional retraction. It also causes widening of intercellular gaps, similar to the first mechanism of endothelial cell contraction. It is caused by chemical mediators such as tumor necrosis factor and interleukin-1. It also affects venules only, and the vascular leakage occurs in the wall of the venules only. It is a reversible process in which the onset of vascular leakage within 4 to 6 hours after injury. So, the differences between this mechanism and the first mechanism of endothelial cell contraction are in the type of chemical mediators which induce or cause the increased vascular permeability, and in the onset of vascular leakage. In the first mechanism of endothelial cell contraction, the vascular leakage begins immediately after injury, and it is caused by histamine, serotonin, bradykinin, and other chemical mediators. While in this mechanism of junctional retraction, the chemical mediators are tumor necrosis factor and interleukin-1, and the vascular leakage begins within 4 to 6 hours after injury and does not begin immediately after injury. The third mechanism of increased vascular permeability is immediate sustained response or immediate sustained vascular leakage due to the direct endothelial cell injury. There is endothelial cell necrosis and detachment caused by severe injury, such as in cases of burns, infection, toxins, and trauma. In this mechanism, the vascular leakage begins immediately after injury and persists for several hours or days. So, this is the more serious mechanism of increased vascular permeability, causes loss of large amounts of fluid and plasma from inside the circulation into the extravascular spaces or interstitial tissue, resulting in hypovolemic shock or circulatory collapse, which causes the death of the patient, as in cases of severe burns. So, in the first days of severe burns, the cause of death of the patient is due to the hypovolemic shock, and the first line of treatment of patient with burns is replacement of losing fluid and plasma by giving intravenous fluid and plasma. In this mechanism, the vascular leakage occurs from the walls of venules, capillaries, and arterioles, and all are affected due to the endothelial cell injury and necrosis. Sometimes there is delayed prolonged vascular response or vascular leakage. Sometimes direct injury to endothelial cells begins after a delay of 2 to 12 hours after injury, and the vascular leakage lasts for several hours or days, occurs through the wall of venules and capillaries, as in cases of mild to moderate thermal injury, radiation, and bacterial toxins. The fourth mechanism of increased vascular permeability is leukocyte-mediated endothelial cell injury. The endothelial cell injury is caused by activated leukocytes, mainly neutrophils. This is a late vascular response or vascular leakage, occurs after leukocyte accumulation, activation, and releasing of proteolytic enzymes causing endothelial cell injury or detachment, and mostly affect the venules because the walls of the venules are weak. The fifth mechanism is increased transcytosis of proteins by formation of channels within the cytoplasm to transport the proteins and fluid, and it mainly occurs in the venules. The last mechanism of increased vascular permeability is vascular leakage, occurs from the walls of new blood vessels, which is called angiogenesis. Angio means blood vessels, genesis means formation. So, angiogenesis means formation of new blood vessels during the repair and healing. These new immature blood vessels and tissue repair have weak, leaky walls, permit the leakage of fluid through them, and vascular permeability persists until the walls of these blood vessels become mature. These 6 mechanisms of increased vascular permeability that were previously discussed are responsible for the formation of openings and gaps in the walls of blood vessels. But the movement of plasma or fluid and proteins through these openings or gaps is an active process and requires energy. Normally, in the body there are 2 opposing forces that control the normal fluid exchange and movement through the walls of blood vessels, which are hydrostatic pressure causes fluid to move out of the circulation, and plasma colloid osmotic pressure causes fluid to move into the circulation. Plasma colloid osmotic pressure depends on plasma proteins, mainly albumin. So, the balance between these 2 opposing forces prevents the accumulation of fluid in the extravascular spaces or interstitial tissue. In acute inflammation, there is imbalance between hydrostatic pressure and plasma colloid osmotic pressure. The hydrostatic pressure is increased due to the vasodilation and increased blood flow, causing pushing of the fluid out of the circulation, while intravascular plasma colloid osmotic pressure is decreased due to the loss of proteins, mainly albumin, that leak into the interstitial tissue. At the same time, the plasma osmotic pressure of the interstitial tissue is increased because it is getting proteins and causing pulling up of fluid into the interstitial tissue. So, the net result is accumulation of fluid in the extravascular spaces or interstitial tissue, with the formation of inflammatory exudate and edema. The functions of inflammatory exudates. Inflammatory exudates have beneficial effects and harmful effects. As we previously defined the inflammation as a protective defense mechanism of the body. This definition comes from the beneficial effects of inflammatory exudates, which are: first, inflammatory exudate causes dilution of toxins and chemical agents, then removed by lymphatic drainage to the regional lymph nodes. Second, presence of protective antibodies in the inflammatory exudates help in the phagocytosis and neutralization of bacterial toxins by specific antitoxins. Third, formation of fibrin meshwork in the inflammatory exudate delays bacterial spread and helps in the phagocytosis. 4. Presence of plasma mediator proteins in the inflammatory exudates, which are inflammatory chemical mediators, play an important role in the inflammation. Fifth, cellular nutrition, such as glucose and oxygen, brings with the inflammatory exudate to the cells of the tissue and removed of waste products from them. 6. Promotion of immunity by stimulation of immune system to produce antibodies against the infection during the lymphatic drainage of inflammatory exudate to the regional lymph nodes. The harmful effects of inflammatory exudates are swelling of the tissue due to the accumulation of inflammatory exudate and edema, causes mechanical obstruction of the airway or the lumen with asphyxia, as in cases of acute laryngitis. Also, swelling of the tissue may interfere with the blood supply by producing pressure effect on the blood vessels, causes ischemia of the tissue, as in cases of acute meningitis and encephalitis, in which there is ischemia of brain tissue with increased intracranial pressure, resulting in coma and death of the patient. Other example is ischemic necrosis of the bone, as in acute osteomyelitis. Inappropriate hypersensitivity reactions. All types of hypersensitivity reactions are regarded as a harmful effect of the inflammation and inflammatory exudate. This is a case of acute laryngitis. There is redness and swelling of the larynx due to the accumulation of inflammatory exudate and edema, causes mechanical obstruction and narrowing of the airway lumen, resulting in asphyxia of the patient. What is transudate? How does transudate differ from inflammatory exudate? So, transudate is plasma ultrafiltrate. What are the causes of transudate? Transudate is caused by one of the following. First, increased hydrostatic pressure, as in the congestive heart failure due to the impaired venous return. Second, decreased plasma osmotic pressure due to the hypoproteinemia, which occurs with protein or albumin loss, as in the nephrotic syndrome and renal failure, or reduced protein or albumin synthesis, as in the liver failure and liver cirrhosis, or due to the protein malnutrition. Third, impaired removal of interstitial fluid by lymphatics due to the lymphatic obstruction by tumors or other causes. So, transudate is defined as an excess extravascular fluid or plasma ultrafiltrate with low protein content and specific gravity of 1.012 or less. Transudate does not typically result from inflammation. This child has generalized edema due to the accumulation of fluid which is transudate in the tissue and body cavities. He has a puffy face and distended abdomen due to the accumulation of fluid in the peritoneal cavity, which is called ascites. The child has a nephrotic syndrome with protein or albumin loss in the urine, causing generalized edema, and the accumulated fluid is transudate. On the left, this is a pitting edema in the dorsum of the foot due to the congestive heart failure, and the accumulated fluid is transudate. This table shows the differences between transudate and exudate. Transudate is plasma ultrafiltrate with early accumulation, while exudate is an inflammatory fluid with late accumulation. Transudate is clear in appearance, while exudate is turbid in appearance. Transudate is liquid, like serum in consistency, while exudate is viscous, like pus in consistency. Transudate has a specific gravity of 1.012, while exudate has a specific gravity of 1.020. Transudate has protein content of less than 3 grams per deciliter, while exudate has protein content more than 3 grams per deciliter. Cell content is scanty in transudate, while numerous in exudate, mainly neutrophils. Transudate is caused by heart and renal failure and liver diseases, while exudate is caused by acute inflammation. So, it is important to differentiate between transudate and exudate because each one has different causes. If you know the accumulated fluid is transudate or exudate, you can know the diagnosis of the disease or the lesion that causes it. Thank you for your listening.